to break this Quizlet in two because I had a lot of Quizlets. All right, so let's study about spinal cord injury. What's the result of it? Uh, so spinal cord injury can result in the loss of total motor function and sensory function below the level of injury if it is a complete spinal cord injury, or a transection is sometimes how it's called, all right? So here's an example of complete spinal cord injury. It means the spinal cord is severed completely through, okay? Then it's a little bit more straightforward. And the red represents where the paralysis is. So no motor or sensation below the level of the injury. Incomplete spinal cords can end up with a lot of different sequela from the spinal cord injury. All right, the initial treatment for spinal cord injuries is spine and cervical stabilization. So for cervical stabilization, they use a cervical collar, and it's a hard collar. Sometimes it's called a Philly brace. And you don't take this off until the provider says you can take it off. Because if the cervical spine is not supported, the patient may become paralyzed when they weren't paralyzed to begin with, okay? I just talked about that. Do fractures of the vertebral column always result in spinal cord injury? No, they don't. And your patient may need skeletal traction or a halo device, and we'll talk about that later. Quadriplegia is tetraplegia, and it's paralysis of all four extremities. SCI of C4 and above results in impaired ventilation. So sometimes the people with C3 injuries at the scene usually die at the scene because they can't breathe anymore, right? The nerves that innervate the respiratory system are in C3, 4, 5, keep me alive, but 3 mostly is the one. If they get that severed, they're going to be on a ventilator for the rest of their life. All right, so paraplegia is paralysis of the lower extremities, so below T1. Some of the causes of spinal cord injury include trauma, diving accidents. Don't ever dive in water you don't know the depth of. Gunshot wounds and hyperflexion, they're caused by diving. So the risk factors, males 16 to 30, because they're very impulsive, especially in the teen years. They're invincible. They feel like nothing's ever going to happen to them, and so they can do risky things, let's say that. Impact sports like boxing, football, etc., they can be at risk. Alcohol and drug use can impair, your ability to drive, so don't do that. Diseases like metastatic cancer, and falls in older adults. So whenever anybody has a spinal cord injury, you're going to look for a head injury too, and vice versa. If somebody has a head injury, you're going to look for a spinal cord injury. Older adults fall because their sight diminishes as they get older, so they can't see, especially in the dark. They have many medications that they take. They have chronic hypertension, so many of them are on antihypertensive medications that make you dizzy, right? You get orthostatic hypotension. So that's why they're at risk for falls. Spinal shock. Spinal shock is common after spinal cord injury. It's where the spinal cord swells, okay, above and below the level of the injury. It causes a total but temporary loss of all reflexes below the lesion, and it may last 1 to 3 weeks. Not only reflexes, but sensation and motor function, okay? Spinal shock is often confused with neurogenic shock, and we did that case study in class, and we kind of defined the two of them, spinal shock versus neurogenic shock. So neurogenic shock occurs in spinal cord injuries that are T6 or above, okay? And it's due to the interruption of the sympathetic nervous system. So that was one of the questions I asked on the case study. And you should definitely go back and read all the rationales for all the case studies we did, because I hand wrote those, and they're very good rationales. It'll help you understand the content a little better. What will the nurse find upon GI assessment? So anybody with a spinal cord injury, that's a big stressor, right? They're going to be at risk for paralytic ileus. Usually develops within 3 days, and they're going to be at risk for stress ulcers. Stress ulcers occur in stressful injuries, and we'll be talking about it again later in the semester. But if they do have a paralytic ileus, they're definitely going to need an NG tube because you don't want them to aspirate. So you want to make sure you put that in. Spinal shock is a complete but temporary loss of motor, sensory, reflex, and autonomic function that occurs immediately after the spinal cord injury. How long does it last? It varies. 48 hours, but it can continue for several weeks. When will the nurse know spinal shock is resolving? Their reflexes start to return. Reflexes are muscle spasms, they're involuntary, and they occur frequently in patients with spinal cord injury. Neurogenic shock results in massive vasodilation, which causes pooling of blood in the blood vessels. And so that puts them at risk for DVT, high risk for DVT. So you need to explain to the family and the patient that you'll be inspecting their calves. You also need to teach the family how to inspect their calves. Okay, when does neurogenic shock occur? 24 hours post spinal cord injury. Signs and symptoms that are different than other shock is that with this shock, they have a decreased heart rate. Neurogenic shock is the only shock that presents with bradycardia. So they'll have bradycardia, then they'll have hypotension, and depending where the injury is, they may have altered respirations. Now, they can develop high or low temperatures because they have something called poikilothermia, which means they're unable to regulate their temperature. They take on the temperature of the room. That's why it's really important that you keep the room warm, okay? And I already talked about DVTs. They're high risk for that. The treatment for neurogenic shock, we did that case study. Atropine increases the heart rate, and dopamine and phenylephrine are going to increase the blood pressure. Okay, dextrin is a fluid expander that you probably learned about, I think, in IV therapy. The priority body system in spinal cord injury is going to be respiratory because you want to make sure your patient is breathing. Bowel function is treated with stool softeners and bulk forming laxatives. Digital stimulation if recommended. So some people may need the digital stimulation. Autonomic dysreflexia is highly tested. Okay, so you need to know everything you can about it. So it happens in people with spinal cord injury that occurs in T6 and above. And it's triggered by noxious stimuli at T6 or below. So it's below the level of the injury. And it could be that their clothes are too tight. It could be pressure areas. It could be decubitus, what do we call them now? Pressure injuries. They could have fecal impaction. They could have a full bladder. It can happen from having sex. It could happen from having a wrinkle or having a fan blow on them like a draft. Okay, so they are going to have vasoconstriction below the level of the injury. So they'll be pale, cool, and they won't sweat. Above the level of the injury, they do have vasodilation, and they're going to have a banger of a headache. They're going to say, I have a throbbing headache. It feels severe and it hurts. They'll have a flush face, distended neck veins, decreased heart rate, and they can be diaphoretic. Okay, so those are the signs and symptoms. The first thing you're going to do if you have a patient like this, you want to make sure you get them upright because that's going to drop the blood pressure right away. And it's life-threatening because you're worried that they're going to have a stroke from the hypertensive emergency. So again, signs and symptoms: severe throbbing headache and blurred vision. That's another thing. Diaphoresis above the level of the injury, nausea, nasal congestion, bradycardia, piloerection, which is goosebumps. They'll be pale below the level of the injury and flushed above. Okay. So the hypertensive emergency can result in stroke, MI, and seizure. So that's why we don't like autonomic dysreflexia. All right. So patients with lesions below T6 do not experience autonomic dysreflexia. All right. Interventions. First, sit the patient up to induce hypotension. Head of bed should be 90 degrees. Loosen constrictive clothing if they're wearing constrictive clothing. Determine the cause, like a full bladder, bowel. If they have a Foley indwelling catheter, make sure there's no kinks in it. Look for wrinkles in the sheet. Pressure on the lower limbs. If there's a fan in the room, make sure it is not blowing on them. And I would turn it off and take the fan out. Administer antihypertensive. So you know you never leave a patient in distress. So you're going to put the head of the bed up, call for help, and typically they have something PRN for blood pressure, so you can call out and have somebody bring it to you. What conditions trigger autonomic dysreflexia? The full bowel or bladder, and its noxious stimuli below the level of the injury. Okay, so no abrupt temperature changes either. So to prevent, you want a straight cath, or teach the patient how to straight cath, which means intermittent cath, okay, every 4 to 6 hours. If they do have a Foley, check it frequently to make sure there's no kinks, prevent constipation, maintain even room temperature. There are several types of cervical traction. Halo or tongs pulls the spine into place. So when is cervical skeletal traction indicated? When the cervical vertebrae is fractured or dislocated. So let me pull up this. So this is skeletal traction. They have pins in their head, so you would do pin care. Remember, we let the weights hang freely. Okay. Whoops. And then this is a halo device. Okay, so this is to stabilize the cervical spine. Okay, and so there's two, you can't see it in this picture, but there's 2 pins in the front and 2 pins in the back, and you would do pin care on them, and you never tighten the pins or remove the pins. Only the provider does that. Now, this is the vest they wear, and you should be able to fit 1 finger between the vest and the skin. Okay, and there's a key that opens this vest in case the patient needs CPR. So tape it to the vest. The vest should be washed once a week in the washing machine or however they wash it. Okay, so you would provide pin care, look for infection, look for, chest and back skin breakdown. It's used to immobilize the cervical spine. They can't drive because it obstructs their vision. I already talked about 1 finger in between the vest and the patient's skin. Yes, they can have sex. They can assume a position of comfort, but let their whoever know they can't hold on to the fixator. The nursing implications for halo traction regarding food and fluids is they have to have straws because they cannot bend their neck. They cut food into small pieces so they don't choke and increase fluids and fiber to combat constipation. It's a safety issue wearing a halo device because it throws off the patient's balance, so they're at risk for falls. You already know, important nursing implication for patient with cervical tongs, that's skeletal traction. So weights hang freely and ensure the cervical tongue is in good body alignment, okay? And you would log roll somebody with cervical tongs. And the benefit of the halo is it allows them more mobility than the cervical tongs, because with the cervical tongs, you're going to be in bed, on bed rest. Okay, so let's do meningitis next. Okay, meningitis is inflammation of the meninges of the brain and spinal cord. What can cause it? A lot of things like middle ear infection, pneumonia, sinusitis, having drains like a VP shunt, or I have a drain in my ear. So having that can put me at risk for meningitis. Open TBI, shunts, ventricular drains. So an open traumatic brain injury, when the skull is fractured, we call that a basilar skull fracture. Okay, ventricular drain is put in the ventricle of the brain to drain excess cerebral spinal fluid. My daughter works in a neuro ICU. She loves it, and they frequently have these external cerebral spinal fluid drains. VP shunt, I've talked about that. That's due if somebody has hydrocephalus, they'll get that. Signs and symptoms of meningitis include seizures. Most of the conditions we're talking about for this lecture, seizures could occur, okay? High temperature, they're going to be confused or irritable, tired, they'll have a headache, they could have aphasia, will have photophobia, definitely. Projectile vomiting is a sign. Petechiae, if it's due to meningococcal, and a rash. So they have a petechiae rash. Emesis, I talked about that, projectile. And then nuchal rigidity means a stiff neck. They could get nystagmus. Remember, that's the involuntary movement of the eyes. Sensitive to sound, so phonophobia, tachycardia, and episotonus. Episotonus, you can look that up if you want, but it's basically like arching their back. Okay, so that would be a late sign. The classic signs are fever, stiff neck, nuchal rigidity, change in LOC, and rash. Okay, what are the meningeal signs? Brudzinski's sign, so that's severe neck stiffness. Causes the patient's hips and knees to flex anytime the neck is flexed. And Kernig's sign is severe stiffness of the hamstrings, and they can't straighten the leg when the hip is flexed. All right, droplet precautions are indicated for anybody with bacterial meningitis or meningitis, I should just say. It's reportable to the public health department. Get them in a private room. They need to be on seizure precautions and prevent and treat increased intracranial pressure. So preventing increased intracranial pressure looks like giving them a stool softener, put them in a quiet, dark room, reduce fever, avoid hip and neck flexion, so no big puffy pillows, no bending, monitor for shock, no coughing and sneezing. So there is medication we could give like lidocaine to stop coughing. Head of bed 30, and the neck needs to be in a neutral position. Don't cluster care. That means doing everything all at once, which we love to do to get it off our plate, but we can't with meningitis. Give antibiotics. Get that in right away if it's bacterial meningitis. How is it treated? Well, you need to monitor the increased intracranial pressure. So the normal value is 10 to 15. Give osmotic diuretics such as mannitol. Give corticosteroids. We don't give it for TBI, but it works in the mnemonic, okay? So we're not going to give it in TBI, but we're not going to give it in spinal cord injury, okay? Hyperventilate after the first 24 hours. This is to make them a little more alkalotic because having a high PaCO2 can result in vasodilation in the brain and increase intracranial pressure. Give muscle relaxants, oxygen, maintain a low PaCO2, and they would do that with hyperventilation and check perfusion. Okay, the first sign of increased intracranial pressure is a change in the LOC. Which medications are used to treat meningitis? There they are. Acetaminophen, anti-seizure meds, and antibiotic. And it's diagnosed, they tell the difference between like bacterial and viral meningitis by the LP and by looking at the cerebral spinal fluid. All right, let's go to TBI. Okay, TBI can cause by a lot of different things, right? A lot of different kinds of injuries. Now, we kind of already talked about this, What is the risk factors for TBI? Very similar to spinal cord injury, right? The same. Males, teens to 30s, ETOH and drugs like, alcohol, drugs, and machinery don't mix. Older adults, we talked about them having poor sight, poor strength too. Like if they're climbing on a ladder, they may fall. Polypharmacia, um, chronic hypertension, they take antihypertensive drugs and they get orthostatic and fall. Psychiatric or cognitive disorders, and of course, contact sports. Health promotion and maintenance for TBI. Wear helmets for anything you're doing on wheels or if you're on horseback. I mean, wear helmets for everything. Wear seatbelts. Don't drive while impaired. That's a good tip. Prevent falls, especially for older adults who don't always want to listen to you. Safety equipment in showers and bathtubs. Don't dive in shallow water. Wear hard hats on the job. Also, like with trampolines, make sure they're at ground level. And there's a fence, not a fence, like around the trampoline. Okay, so the children can't fall off it. Mild TBI is a Glasgow Coma scale of 13 to 15. It is considered a concussion. Okay, they may or may not lose consciousness. They may have amnesia. If they do lose consciousness, they'll complain about a headache and pressure in their head. They may lose their balance. They may become dizzy. They may have nausea and vomiting, confusion, and be sluggish. They're really treated and treated with a TBI, right? So you treat the symptoms and they tell them they need to sleep and rest a lot so they can heal, and a gradual return to ADLs. One concussion within 10 days of another concussion increases the risk of further brain injury. What does the nurse need to prevent when a patient presents with an open skull fracture? Infection and increase intracranial pressure. A basilar skull fracture cannot be detected on like CAT scans and MRIs, so it's really important you know what the signs and symptoms are so you can identify it. And it's a fracture at the base of the skull. So I'm going to show you this picture because this might help. Okay, so it's a fracture. This is the base of the skull, okay? The patient's going to present with these raccoon eyes, so ecchymosis around the eyes. They also have what's called battle sign right here. And this is, or they could have it like at the mastoid process. That's another area. And it's bruising around the mastoid process and behind the ear. Now, they could have bloody or clear drainage coming out of their ear or nose. So you want to test it for halo sign, okay? Now, if it's cerebral spinal fluid, it will have glucose in it. But if you're testing bloody drainage, it's going to have glucose anyway because blood has glucose. So always do halo sign because that will tell you if it's cerebral spinal fluid. Okay. This is halo sign. So you take the fluid from the nose or the ear and put it like on a gauze pad. And you'll have these concentric rings. And it looks like a halo. Otorrhea is ear drainage and rhinorrhea is discharge from the nose. Bloody or clear drainage from the ears or nose are characteristics of CSF leakage. The interventions you want to do in managing of leaking CSF includes head to bed 30, no pillow, head and neck in proper alignment. You can put a mustache dressing or an ear dressing, but don't pack it. No blowing or picking nose, no coughing or sneezing, no hip flexion. Manage fevers. Temperatures cause increased intracranial pressure. They need stool softeners and pain control. So when the patient's discharged from the hospital, because they don't keep them for a concussion, family must watch the patient for 48 hours. It doesn't mean they have to keep them awake for 48 hours. Don't leave the patient alone. The patient needs to avoid straining and bending. No driving, no operating heavy machinery, no power tools, no contact sports. Report back with vision changes, balance problems, a change or behavior, or decreased LOC. So if any of those happen in the first 48 hours, they need to report that. The earliest sign of increased intracranial pressure is decreased LOC. Okay, your patient may become sleepy, lethargic, they may become agitated. Later signs include the pupil changes on the ipsilateral side of the injury, so that means the same side of the injury. They can develop hypertension with a wide pulse pressure and bradycardia and have a change in their respiratory pattern. So those three things, hypertension with a wide pulse pressure, bradycardia, and a change in respiratory pattern. Those three things together are called Cushing's triad, okay? So don't get it confused with Cushing's disease that we're going to talk about in endocrine. This is Cushing's triad. Which condition should the nurse monitor for a patient with a closed head injury? You're going to monitor for brain herniation and diabetes insipidus. Brain herniation happens because there's only so much space in between the skull. And if you get like a hematoma or you have a tumor, the brain is going to start shifting. And then, let me see, and then it can herniate down. See number 6? The brain can come through the foramen magnum and herniate. All right, diabetes insipidus means there's no ADH, okay? They're going to be dry inside because they're going to be putting out large amounts of urine. They're going to be thirsty, okay? So watch for increased intracranial pressure and monitor, give the osmotic diuretic, which is going to be mannitol, corticosteroids, but not for TBI or spinal cord injury. Hyperventilate for the first 24 hours. We talked about this to maintain the PCO2 30 to 35. So make sure they don't get hypoxic either. You're going to put them on seizure precautions. No flexing of hip or neck. Don't cluster care. Don't allow the patient to cough or bend. Give a stool softener and put them in a quiet, dark room. Should you cluster care? No, you're doing too much if you do that. It will result in increased intracranial pressure. The PaCO2 is kept on the low end because CO2 is a vasodilator and it increases intracranial pressure. The meds you can use, we did a case study on this with mannitol. Furosemide can also be given, morphine, phenytonin, and phenobarbital. We don't really do that as much anymore, but we used to put people in barbiturate comas to kind of rest the brain. Glasgow Coma Scale, that's moderate brain injury, is 9 to 12. Less than 8 means you need to intubate. A severe injury is 3 to 8. A change in the Glasgow Coma Scale of more than 2 points lower is significant. What time of bleeding is an epidural hematoma? It's arterial bleeding, which means that it's fast bleeding, okay? It's also known as talk and die syndrome. The cardinal sign of an epidural hematoma is a lucid interval followed by rapid decline, okay? So a lucid interval means somebody's unconscious, right? And they wake up and they have the same mental status they always had, right? That's an ominous sign that they are going to start declining quickly. Other signs could include periorbital ecchymosis, seizures, nausea and vomiting, headache, ipsilateral pupil change. So ipsilateral means same side, right? So epidural, again, is arterial bleeding. Subdural is venous bleeding. So subdural is going to be a slower bleed, okay? And that usually happens to older adults or chronic ETOHers. Because these conditions shrink the brain so there's more space between the skull and the dura. Okay? Symptoms, they're going to have ipsilateral pupil changes, contralateral hemiplegia, or paresis. The treatment is going to be emergent surgical evacuation of hematoma. Subarachnoid hemorrhage is usually caused by bleeding of an AVM or an aneurysm. So it's kind of a surprise to people, to be honest with you, because cerebral aneurysms have no signs and symptoms. So when somebody ends up with one of these, they're like, how did this happen to me? The classic sign is the worst headache of my life. What other types of signs and symptoms would they have? They would have visual disturbances, photophobia, nuchal rigidity, headaches, seizures, nausea and vomiting, and a decreased LOC. Causes are aneurysms and AVM usually. Now they're going to be at risk for a rebleed 7 to 10 days after a hemorrhage because the arteries start spasming, so they get vasospasm. So they're going to get nimodipine to treat that because it crosses the blood-brain barrier. Okay. Decerebrate posturing, you need to know. Okay. And this is worse than decorticate. Okay. All right, that does it for the Quizlet review.